Thank you, moderator. Good afternoon, professors, doctors, and colleagues. First of all, I would like to express my gratitude to the committee. It is an honor for me to be invited to this webinar. My talk at this occasion is about fluid and monitoring as the primary modality of dengue case management. I will start with the global and national dengue burden and strategy, and then a bit about pathogenesis, and followed by diagnosis, classification, and treatment of dengue, and of course, about fluid management of dengue. As we know that WHO estimate currently around 3.9 billion people are living in area with risk of dengue transmissions, and it is including 179 countries, mostly are in Asia. And around 390 million dengue infections occur yearly. About a quarter of them will manifest clinically. In 2017, there's also a research showing that dengue was affected equally in a female and male. And based on the data, we know that country with highest incidence rate are Barbados, Dominica, and in the third place is Indonesia. This is about global and national strategy to control dengue. WHO stated that by 2030, there should be end of the neglected tropical diseases. And we know that dengue is one of the neglected tropical diseases. The targeted for control dengue, we can see that by 2030, we hope the case fatality rate due to dengue will be 0%. And to achieve this target, there are three fundamental critical action. First is continue developing preventive vaccines for all at-risk populations, followed by further develop the evidence based on effectiveness of vector control program. And then the last is continue collaborating with environmental sectors, engineers to reduce mosquito habitats. The chart in the left showing us the incident rates and case fatality rate in Indonesia. Over 50 years period dengue existed in Indonesia, we can see that the incidence rate still up and downs. However, the case fatality rate could be maintained below 1% for the last couple of years. In Indonesia, had already stated in the Indonesia's National Medium-Term Development or RPDMN 2020-2024 that dengue is listed as a potential disease-causing outbreak, and there are discussed that the strategy for improving diseases should be controlled. Based on this RPDMN, by 2024, we targeted that 90% districts and cities in Indonesia have incidence rate of dengue hemorrhagic fever below than 49 per 100,000 populations. And to achieve these goals, we need a national strategy for dengue control to be developed. I will back to the immunopathogenesis of dengue infections. A primary exposure to dengue virus induces both humoral and cellular mediated immune responses. During a secondary infection with the different dengue virus serotypes, cross-reactive non-neutralizing antibody will bind the virus and enhance a viral uptake via Fc gamma receptors, and it will resulting in enhanced viral replication and also higher antigen loads. Dengue virus may have direct effect also to endothelial cells, and mediators released by T cells and by virus-infected cells along with the complements activations and immune complexes, may result in enhanced vascular permeability and also coagulopathy. And we can summarize that the two major pathophysiology of severe dengue infection will be due to the plasma leakage, which can lead to hypothalamic shock and bleeding, who can leading to the hemorrhage. This is about the clinical course of dengue infections. We know that the course of dengue infection will be started with the febrile phase and then followed by critical phase and ended by recovery phases. And it will be last around 2 until 7 days. During the critical phase, which is occur around 24 to 48 hours, it might be there are some potential clinical issues happens, such as shocks due to severe plasma leakage, bleeding, or severe organ impairments. This is the major manifestation change of dengue. We need to observe carefully the signs and symptoms which appear at different phases. During the febrile phase, the potential issues or complications such as high fever, it causes dehydration or maybe convulsions due to high fever, mostly in young children, should be observed. And during the critical phase, where the plasma leakage could be occur, maybe also accompanied with a hemorrhage or organ involvement. And then in the convalescent phase, this is the phase where the reabsorptions occur. We should observe whether any potential complications such as intravascular fluid overload due to continual aggressive volume resuscitation during the convalescence phase. We know that currently there are some guidelines that we can follow. WHO has 2009 guidelines and also 1997 and 2011 guidelines. So now the question is, what is the best management for dengue? So far, there is no specific therapy is available for symptomatic dengue infections. And the evidence shows that the effective treatment relies on good supportive care, in particular emphasis on fluid therapy and also management of bleeding complications. This is the algorithms, trials and acute management of dengue in pediatric casualty. So if we have a patient with suspected dengue presented in our clinic, then we need to identify whether this patient presented without warning signs or with warning signs or severe dengue, because each of them had a different approach of management. Those without warning sign will be put into group A, and it is ambulatory. Group B, those with warning sign, need to be observed in hospital for further managements, including administration of IV fluids. And those who enter into group C or severe dengue need to be admitted to high dependent care unit or pediatric intensive care units. This is a algorithm for a patient with compensated shock. We know that in shock condition we should give high amount of fluids intravenously, and then we need to observe whether any improvement after fluid administrations. If the condition or the hemodynamic is stable and the hematocrit also is going down, we should follow by observation and reduce the rate of infusion rate. If the condition otherwise is not improved, then we need to give further fluid resuscitation and check whether there is increasing or decreasing of hematocrit to consider whether we need to give blood transfusion or not. For a patient with hypotensive shock, then still intravenous fluid should be administered more aggressively. So we should give intravenous fluid as soon as possible. Then we need to observe whether any improvement in the hemodynamic. If there is improvement, then we reduce the rate infusions accordingly and stop after 48 hours. If the condition is not getting better or improve, again, we need to check whether the hematocrit is still high or the hematocrit is going down, and we decide whether we need to further give intravenous fluid resuscitation or we need to give blood transfusions. About evidence of fluid management for dengue. Dengue shock syndrome can be treated successfully with isotonic crystalloid solutions. And if a colloid is considered necessary, clinicians must continue to rely on personal experience, familiarity with particular products, local availability, and also cost. A medium molecular weight preparation that combine good initial plasma volume support with good intravascular persistence and an acceptable tolerability is probably the optimal choice. The main types of volume expander are crystalloid solution and also colloid solutions. This is to replace lost fluids in the management of dengue. The crystalloid solution, such as the normal saline or ringer lactate, are the most preferable initial fluid for volume replacement in the management of dengue shock syndrome, because it can distribute it throughout the extracellular space as a large quantity, and also a rapid infusion of a large volume of fluid may be well tolerated in a healthy child, but we need to be careful in critically ill child, and reassessment after every fluid bolus is critical. While colloid solution, we know that such as 5% albumin, fresh frozen plasma should only be reserved for patients presenting with profound shock or those who do not respond to the initial crystalloid therapy, because it is less widely available and may take time to prepare. Blood-derived colloid solution may cause sensitivity reactions, so we need to be careful. And synthetic colloid may cause coagulopathies. Excessive administration also can lead to pulmonary edema. Recent studies on a solution such as crystalloid solutions, human-derived colloid solutions such as albumin, fresh frozen plasma, and also synthetic colloid solutions such as dextrans, gelatins that are used in dengue management show different characteristics. For example, like isotonic crystalloid solution, it has effect on volume distribution, where it's rapid distribution throughout the extracellular fluid with small hematocrit dilution effect, while colloid solutions who has large molecule have penetrated to the glucocalyx layer, endothelial glucocalyx layer, slowly and gradually distribute throughout the ECF and have a greater initial hematocrit dilution effect. Crystalloid solution have plasma oncotic pressure falls, while human colloid solution could make plasma oncotic pressure rises. We are not know currently about the potential effect when endothelial glucocalyx layer barrier function is compromised for the crystalloid solution. but for colloid solution may penetrate the layer more easily and reducing the effect on plasma oncotic pressure. For effect in profound shocks, there is no difference between crystalloid solutions and also colloid solution. And there is no potential to restore structural or functional characteristic of endothelial glucocalyx layer in crystalloid solutions. This is an interesting study from Queen Sirikit National Hospital in Bangkok. The study is about case management of dengue, including the time from 2008 until 2015. We can see in this table that for overall case fatality rate is around 1 until 5%, but for walk-in patient, the case fatality rate is only 0.1%. This is also the list of problem and also the solutions based on study in Bangkok. So when the problem is related to the improper diagnosis and triage of dengue, delayed in diagnosis of dengue and or severe dengue, then the solution is earlier recognition and clinical laboratory diagnosis. And when the problem is related with improper recognition and management of plasma leakage, then the solution should be optimal fluid management of plasma leakage during the febrile and critical phases. And when the problem is related to the complication of prolonged shock or multiple organ failure or expanded dengue syndrome, then the solution is related to the earlier recognitions and management of severe dengue to avoid prolonged shock. So we can say that the improper recognition and management of plasma leakage could delay fluid resuscitation and also can relate it to the fluid overloads. So the solution is optimal fluid management of plasma leakage during the febrile and critical phases, such as avoid unnecessary intravenous fluid during the febrile phase, or limit administration of intravenous fluid during the leakage phase to maintain urine output, or use of hypertonic colloid or plasma volume expander when response to crystalloid infusion is insufficient or failed, and recognition and management of volume overload during the resorption phase, or maybe by giving diuretics for treatment of volume overloads. This is another study from Sri Lanka, just to show us comparisons of the requirement of total IV fluid intake between dengue hemorrhagic fever and dengue fever. It seems that the fluid requirement in the HF group is much higher compared to the dengue fever group. And the other study, this is a pilot study from Malaysia. This study was take place in primary settings. This is a randomized control study, a 2 months period at primary care clinic involving 143 subjects, where the inclusion criteria is patient older than 12 years old with suspected dengue fever and thrombocytopenia. So the intervention is giving a fluid chart and also a cup, and the control group is dengue home care, with the main outcome is hospitalization rates, IV fluid requirement, total oral fluid intakes. So what is the results? The result is showing that even though there is no statistically significant difference between the intervention and the control group, but fewer patients in intervention group required IV fluids, and increased amount of daily oral fluid in the intervention group. And the conclusion is that the fluid chart is a very simple and inexpensive tool that may reduce hospitalization and intravenous fluid requirements in suspected dengue patient. But of course, there's also suggestion that maybe we need a larger population to see whether this study could be also extend to other greater populations. What about the blood transfusions? When blood transfusions should be administered, blood transfusion can be life-saving for patients with severe bleeding that compromises cardiovascular function, but it should be undertaken with care because of the risk of fluid overloads. Platelet concentrate, fresh frozen plasma, and cryoprecipitate may also be needed, depend on the coagulation profile. However, currently there is no evidence that prophylactic platelet transfusion have any value in patients who do not have clinically significant bleedings, even when the thrombocytopenia is profound. Studies in pediatric patients of dengue shock syndrome have shown no benefits of prophylactic platelet and FFP transfusions. Instead, such transfusions are the cause of fluid overload and prolonged hospital stay. And this is the guideline for transfusion in dengue. So platelets are indicated only in severe bleeding. Even if there is a bleeding, consider cells transfusion first. So this is the indication for platelet transfusion for those who have platelet count less than 50,000 with severe bleeding or invasive procedure is planned. And for those with platelet count is less than 20,000, it should be with severe bleeding or clinically unstable conditions. It means that a patient with a shock or associated risk factor are presented. Or the platelet transfusion indicate in patients with platelet counts less than 5,000 with minor bleeding. Do we need corticosteroid for dengue treatments? There is a systematic review about corticosteroid administrations in preliminary stage or in intermediate stage and late stage. This systematic review come from limited trials, and the conclusions show that there was no evidence that the use of corticosteroids in dengue will result in viremia or any other significant adverse effect or complications. The effectiveness of corticosteroid in dengue is depend upon the sustained and maintained therapeutic blood levels of corticosteroid for an adequate duration and using a steroid with higher receptor affinity. So this is the last slide of my presentations. Understanding the burden of disease, the pathogenesis, and also the natural course of disease is fundamental in order to achieve the target of dengue control program, where by 2030 we need to reduce the case fatality rate of dengue into 0%. In the absence of antiviral, then fluid management needs to be implemented thoroughly. Evidence also showed that by close monitoring and adequate fluid management can reduce hospitalization and also save the lives of dengue patients. Thank you.